Okay, good evening and thank you organizers. Can I have the first slide? So I think the idea is to have a discussion on prostate cancer to put things into perspective. So before we, we're talking of metastatic prostate cancer. So my first slide says regional prostate cancer and how do you define that and what is the approach before we go on to the proper metastatic disease. So Dr. Ranjit Sahu, are you there, sir?
Sir, he's not there, sir.
Sir, I think he's not there. Okay, Dr. Dongre from Nagpur, please. Dr. Amol Dongre.
Hi, sir. Hi, I am there. Hi, good evening.
Your comments on, going in for the thought for regional prostate cancer. So, Amol, are you there?
Sir, sorry, sir. I didn't get. I just joined. I don't know. Sir, what happened, sir?
So the question is, when you're looking at a patient with metastatic prostate cancer, so if the disease is confined to the pelvis, so do you look at that angle of regional prostate cancer versus a widely metastatic disease? How do you, look at your patients with metastatic prostate cancer?
So, well, sir, once we label these patients metastatic prostate cancer, then obviously, we look into that only stage 4 metastatic. I didn't get what exactly you wanted to ask, like regional prostate cancer. I'm not getting this, sir. I'm sorry.
If you look at the NCCN guidelines,
they
divide the prostate cancer metastatic disease into, regional prostate cancer versus, can I have the next slide? Is there a comment from any of the panelists there? Dr. Arun or Dr. Ankit Agarwal?
Yes, sir. I think what I look at is oligometastatic versus something less than maybe 5 mets, something that can be targeted, versus something that's diffusely metastatic. That's what I'd look at, and also the low burden and the high burden. These are the two questions I would.
Now we'll come to that, but the idea of discussing this regional thing is if somebody has. Yeah, please.
Sir, this is Abhishek this side from Lucknow. So I think regional prostate cancer, we need to have a newer edition in the NCCN guideline. It says that those cancer which are proceeding beyond the prostate and they are involving the local sites or along with the lymph nodes. And according to a SEER review, they say that even in this setting, the 5-year survival is almost approximately 100%. So there are some variations in treatment that we have to look into this particular entry, which is a newer addition in the NCCN guideline.
Right, absolutely. So I think that was the idea of putting this slide here. If you look at the regional, for example, as he rightly pointed out, that if the disease is going even beyond the prostate region and it is, involving the regional nodes, so the treatment, especially if your expected patient survival is more than 5 years or the patient is symptomatic, one should consider, external beam radiation along with ADT, which is the preferred regimen. So rather than, if you have only lymph node metastasis in the pelvic region, I think a lot of people are only happy with ADT with or without abiraterone. But I think the role of EBRT cannot be ignored. That was my point, which I wanted to put across. So any thoughts from Dr. Nikhil or Dr. Ankit? Can you go back, please?
Yes, sir.
Yes, sir.
Dr. Ankit here.
Yeah, Ankit.
Yes, I think regional prostate cancer also needs to be taken care of, just like prostate cancer, which is non-metastatic. I think EBRT plays a very important role in these patients. Obviously, ADT has its own role. We should be we should be offering EBRT to these patients also. They should not be treated as a widespread disease.
Right. And I think this is also important to understand that if the expected patient survival is less than 5 years and the patient is largely asymptomatic, well, then it could be ADT alone or observation rather than subjecting these patients to radiotherapy. So our practice, I'll tell you, for example, today I saw a patient whom I've been treating for the last 6-7 years. This patient has prostate cancer, and this patient had a lymph node in the para-aortic region. So it is even beyond the pelvic region. So 6 years ago or 7 years ago, we put the patient on ADT, and patient has now, the PSA has gone from 0.6 to 0.8, and we saw the node, which was earlier 5 centimeter, had gone down, and now it has started increasing. So my thought was to consider a radiation for this individual rather than adding abiraterone, because 7 years ago the patient is on Zoladex. So the thought is whether to give abiraterone or to think of local radiation. So I have sent the patient after discussion with the radiation people, because he's still like 60-65 years, and so the point is to consider radiation therapy for patients who have regional disease instead of just thinking in terms of hormonal therapy. So that is the point I wanted to bring in this particular area, this slide. So any comment from anybody before I move on? Okay, I think can we move on to the next slide? So this is another point which I think has not been discussed, but then the issue of, you see here, risk group is regional on metastatic disease, and we are talking about germline testing, which is recommended in both the groups. And for molecular and biomarker analysis of the tumor, especially recommended for the metastatic disease, which is M1, for HRR, or consider tumor testing for MSI and the mismatch repair deficiency. So this is an important test which I think we are missing at this point in time. So I want the comments from, from Abhishek. What do you think? So are you doing this test?
Sir, no, I don't do this test because practically, if we want to utilize these tests in our clinical practice, we should offer, if something which comes as indicated according to the molecular test, if some tests are positive. So I don't know whether treatment affordability and all, because the reason where I practice, affordability would be a problem. So generally I don't do, but yes, it is recommended. So we should do it.
Right. So I think any other comment? I agree with the funding part. Although the MSI has become fairly readily available, but yes, HRR is very expensive. Which is the homologous recombination gene, which is the HRRN. Any other thoughts here before we move on?
So if the patient can afford to take the immunotherapy or the olaparib, then that's when we proceed with testing. But if a patient is not able to afford, then as you said, as Dr. Abhishek said, we've kind of, I don't tell them about this actually.
Right. So I think, one of the Dr. Sahu made this point in his presentation, that PARP inhibitors have been approved. So keeping that in mind, so not only the germline testing in the blood, but also on the tumor. So one should consider doing the HRR and the MSI. So next slide, please. Just a word about intermittent ADT. Who's following intermittent and who's following continuous ADT? So any thought process there? Because Dr. Amol Dongre, Dr. please.
So I'm following mostly a continuous ADT. I'm not following intermittent ADT.
So continuous. Abhishek?
I follow continuous ADT, but if patient is having good compliance and he is committed to routine follow-up with PSA, testosterone and radiological follow-up, I might consider using intermittent ADT, considering the non-prostatic side effect profiles. So, great. But my practice is continuous ADT.
Yeah, Dr. Ankit and Dr. Arun, please.
So I'm also not practicing intermittent ADT as of now. It's mostly I've been using continuous ADT.
Next slide. Next slide.
Same thing here, sir. I've not had too many side effects.
So this is the from 2020 NCCN, a phase 3 trial that compared intermittent to continuous ADT showed that intermittent ADT was not inferior to continuous ADT with respect to survival. and quality of life was better for the intermittent ADT arm. So, I mean, this is the latest from the NCCN. It can be considered, although you have to read in between the lines to decide, whether to give intermittent or continuous ADT. So there isn't any consensus, but if somebody is doing intermittent ADT, perhaps is not incorrect. Next, please. So now coming to the hormone-sensitive prostate cancer, the approach and the factors. The next slide. So here is a patient with metastatic disease. Gleason score is 9, and patient has multiple bone disease and lymph nodes. So what do what are the factors which make you decide or choose your treatment? Abhishek, please. Next slide.
Sir, I think before this stampede result has come, probably this low risk and high risk would have made difference. But as the results are there that even in the low risk disease, there is a benefit of adding docetaxel or abiraterone. So probably, yes, of course, we can prognosticate, but for treatment purpose, I think there is no much difference right now. I mean, high risk burden disease, definitely we should treat along with ADT, we should add on docetaxel or abiraterone. Low risk, we can take decision based on the discussion.
So as you see here from the charted, one of the following is there for high risk, which is presence of visceral metastasis, more than 4 bone lesions, with more than 1 beyond the vertebral bodies and pelvis. And the latitude, the definition is 2 of the following: Gleason score more than 8, more than 3 bone metastasis, and measurable visceral metastasis. So I think one needs to look at those factors. So, Dr. Arun, any comment on high risk versus low risk disease in terms of approach?
Yes, means what Dr. Abhishek said, that the new trial says that docetaxel can be used in low risk, but I think a low risk with Gleason of 6, 7, perhaps with a low PSA, that's a patient I would avoid docetaxel. If I had a patient with low burden disease as per charted, they don't mention the Gleason and the PSA, but you have a high Gleason, high PSA, that's the low burden patient that I would give docetaxel to. Otherwise, I would, stick with a low PSA, low Gleason, and a low burden. I would still go with abiraterone.
Yeah, Dr. Ankit?
Sir, I think I'll look at the performance status, whether he'll be able to tolerate docetaxel, and if he's willing to take docetaxel, performance status being good, I think I'll prefer docetaxel in this patient, followed by the second line once he progresses after dosi or after 6 cycles.
So, Dr. Amol,
Yes, so definitely PSA of more than 180 and Gleason score 9. I would go for docetaxel, obviously based on the performance status of the patient, but my choice would be to give docetaxel in this patient.
So a patient who has extensive disease will be, and if the performance status is acceptable and is good, well, then you would go for the use of docetaxel. Otherwise, it would be abiraterone, right? So what about enzalutamide? No takers for enzalutamide here? Yeah, Abhishek?
So, enzalutamide, I'll keep, I'll reserve it for next, whenever it is required. Because first line, I'll definitely use abiraterone instead of using enzalutamide. Looking into the recent results of sequencing of this thing. So that strategy I might use for the later progression.
So
Sir, if I may, I think Dr. Vaswani showed a very good data which said that sequencing with abiraterone followed by enzalutamide would be a better option as compared to enzalutamide upfront.
Absolutely.
Although
so
it was only phase 2.
Right. I think looking at the data as it stands today and even the cost factors involved, because enzalutamide still is more expensive. I would like to sequence abiraterone first and enzalutamide later, and if docetaxel would come in. People would think
So just wait for a minute or so. We'll be back with the slides. Just wait for a minute.
I mean, I think that's quite clear today with the availability of the data. Amol, what is your sequence in most of patients of metastatic prostate cancer?
So my sequence could be as I mean, Dr. Bharatwajane showed real good data. So my sequence would be abiraterone, followed by docetaxel, then enzalutamide.
Right. So I think that seems to be the which is coming out.
And obviously, sir, depends on the disease load also. Yeah.
So I think the question is, if somebody has taken docetaxel in the first line, then what is the first line option for hormonal therapy when you sort of have to for progressive disease? Is it enzalutamide or is it abiraterone? If the patient is
abiraterone.
Abiraterone, sir.
Abiraterone.
So I think I mean abiraterone is used before enzalutamide unless there is a contraindication.
Yeah.
So I think we are running short of time as well. So, and the next slide, maybe, you know, is there a next slide, please? There are several slides, I know. So I think the sequencing has become fairly clear that abiraterone, docetaxel, enzalutamide, or docetaxel, abiraterone, enzalutamide. So I think that is what I see from the panel is a consensus. So so what about a repeat biopsy? So there is NCCN says.
Sir Sahu here. Sir Sahu here. Sorry, I'm not in the panel. Can I just come in for a minute, sir?
Yeah, TP.
Yeah, sir. Only thing is that, sir, would we not be looking at the previous response to the enzalutamide or abiraterone to even think of that? Because I feel there is enough data to tell that if there's early recurrence or a lack of response which is beyond less than 1 year to one of these agents, it won't be a good choice to repeat such agent rather than continue with the second line chemotherapy. That's the only small point which I wanted to make.
Okay, so Dr. Sahu is introducing cabazitaxel here.
No, issue is not, there is data enough to support that. That's my point. And what is the panel's view on the mutation of the V7?
Okay, so what, Abhishek, what about, is anybody doing this? Is it available? Is it relevant? I don't know. I mean, Abhishek, your comment.
Sir, I have not done it. I don't know whether it is available or not.
So if it is available, then what?
Even that then also I think I will not be doing it.
Okay. So Dr. Ankit?
No, so I've not done the test routinely, and I'm not very, to be very honest, I'm not very confident about using a cabazitaxel as first line. So
no, it's not.
No, it is the question of second line actually.
Yeah, second line. Sorry. So I don't think I'll be. I'm very confident about doing the test also.
Yeah. So Dr. Arun, any thoughts on ARV7?
So I think the response to the hormonal therapy can be a surrogate for the ARV7. We need not test for it. I think the majority, I think a very minority initially have an ARV7, and as the treatment sequence progresses, then you develop this ARV7 mutation. So I think the response to the hormone therapy would be a surrogate. So I don't think the testing would be very beneficial.
Right. So I think Dr. Tarini Sahu, I think the ARV7 has really not picked up in our
my point was what exactly Dr. Arun told, that if you don't have a response to the first line of abiraterone or enzalutamide, do not consider it as the other agent as the second line. Switch over to chemo. Yes. That's the only small point which I wanted to make.
Right. So therefore the answer to that question from my side would be that if somebody has not done well in the first line abiraterone, well then after docetaxel, I'd like to go for cabazitaxel rather than enzalutamide.
Exactly.
Yeah, exactly.
So I think
I agree with this.
We have a consensus there. So I think we're coming to the end. Maybe one or two more slides. Next slide. Basically coming to the PARP and to the MSI. Next slide, please. Next, I think we'll skip these slides. I think we covered most. I think next, please. Next slide. Next, please. Okay, so this was the, so this is the point I was trying to make. CRPC, conventional imaging studies, positive for metastasis. So they want a metastatic lesion biopsy. So do you do biopsy for a patient who is progressing? Anybody doing biopsy?
No, sir. Not doing routinely.
Routinely, we are not doing so.
Yeah, Dr. Sahu, are you participating in this?
No, I actually don't do biopsies. I will be very frank. Except for lung cancer, I normally, or breast cancer, I'm not very keen, but yes, I would now think about it.
Yeah. So the idea is to differentiate between, conversion to a small cell, particularly if the PSA is not high, which is commensurate with the amount of metastasis. And then of course, yes, Dr. Bharat.
Sir, if in those who are multiple refractory, this small cell incidence is as high as 30% in some of the series. So ideally, if you have a multiple refractory, it should be done, because you may have an option of flattened then, sir. So ideally, we should do it because the incidence of the transformation rate is quite high in a multiply treated patient in prostate. If you see the literature.
Sir, can I make a comment?
Yes, please. Yes.
Sir, I consider doing biopsy in CA prostate once there is high tumor, high metastatic burden and PSA is not rising in that proportion. So in that only situation I do biopsy. Otherwise, I don't. That's my take.
Absolutely, because I think that is the point I was trying to make. That if your level of PSA is,
sir, you're asking for a repeat biopsy or the front line also?
So repeat biopsy.
Repeat. That's it. Okay.
It's a repeat biopsy. CRPC, conventional imaging studies, are positive for metastasis, and they are asking for a metastatic lesion biopsy to differentiate between neuroendocrine.
One more point. Can I make a comment, sir? Because routinely we do the PSMA PET right now. I think a lesion which is not that PSMA avid would point you towards doing a repeat biopsy also. So I think that because of the technology change also, we can incorporate that as a marker.
Yeah, so there are several pointers which could direct us to encourage us to go for a biopsy of the metastatic height. For the PSMA is not taking up, or if the PSA levels are low. So those are the definite candidates for consideration for a biopsy, to look at the neuroendocrine component, and which will make them eligible for a protocol. Of course, it covered the MSI and the germline and tumor tests for HRD on the tumor, not only on the blood sample. So if somebody is able to afford, because that is what the guideline says, because you should be testing for the tumor, BRCA1 and 2 or the HRD. So I think we are short of time. We've covered a few things here. I think these discussions can go on, and I'll thank all my panelists, Dr. Sahu, to be part of the panel, and Dr. Bharat as well to participate. So thank you very much. I'm looking forward to seeing you next time. Thank you very much.
Thank you so much, sir.
Thank you so much. Thanks a lot. Thank you, sir. Thanks a lot.
Thank you.